Children's Hospital in Vancouver, Canada. He's a clinical professor, clinical investigator and head of the University of British Columbia Division of Allergy, where he leads a dedicated food allergy program. He's published over 170 papers, and he's also published the first Canadian guidelines on food allergy treatment. I personally visited his setup last year, and I'm absolutely delighted to hear his talk and to share his pearls with us. So please make Edmund welcome. Thank you.
Okay, thank you, Kirsten, for your kind introduction. Thank you, Kirsten and Jill, Jennifer, and everyone at ASCIA for inviting me to speak. It's an honor and a privilege. I've been really enjoying your beautiful city here of Sydney, and really excited to share my experience with food allergy treatment with you. That was a nice segue from Kirsten right now about CFAR's aims. One of them is on knowledge translation. So both of my talks today will be about how do we implement food allergy treatment in our various healthcare systems. So bear with me here. Okay, my disclosures for this talk, the most relevant are research support from DBV Technologies and being one of the co-leads for the Canadian Society Oral Immunotherapy Guidelines. And so really it was such a nice visit from Kirsten and Angela back in October. It was really a great discussion that we had about sharing experiences with our two different healthcare systems and the practice of food allergy in each. And it really sparked this collaboration where now I've been asked to share my experiences with you. So thank you again to Kirsten and Angela for visiting Vancouver. So my objectives are to firstly describe the evolution of the, what we abbreviate FAIT, Food Allergy Immunotherapy Program at BC Children's Hospital. To secondly illustrate how the FAIT program builds research into clinical care, and to summarize the current state of the FAIT program. So I want to note that we continue to participate at our center in industry-sponsored food immunotherapy clinical trials, but that's a separate branch of our program. And so I'm really going to focus again on the knowledge translation aspect, the implementation. And so take you back and tell the story of our journey, how we evolved into this real-world FAIT program. So I want to take everyone back to roughly 2017, when Brian Vickery and colleagues published the preschool peanut OIT paper, which showed particular safety and effectiveness compared to older children that had been published previously in other studies. And so there was hardly any use of epinephrine in this study, only one subject, and there were no severe reactions to speak for, really. And so with that, there was also extreme effectiveness. They had a 4-week SU, median treatment duration of 29 months, and it showed over 80% SU in both the intention to treat and the per protocol analysis. And you know, it was really what we, as a few of us Canadian allergists sitting in the audience and looking at this data, felt to be a paradigm shift. Because prior to 2017, many of you have had this experience, I'm sure. I was having more and more families in my clinic flying to the US to get oral immunotherapy. And over time, it bothered me quite a bit. They were spending, you know, they were telling me at least $20,000, $30,000, maybe more, to go to various places in the US for oral immunotherapy. I felt that there would be a risk with all the traveling and ingesting their allergens. And so, you know, it was really quite good timing for this study to come out in 2017 when there were more and more families going to the US for the treatment from Canada, and really asking myself, should that scenario continue? And so about 15 of us Canadian pediatric allergists united in 2017 to move past what I describe here to be quote unquote endless debate on whether OIT was ready for use outside research trials. And so I'm sure you've had this experience going to conferences and meetings where there's pro and con endlessly about whether we should start offering it outside of research. And it was getting very fatiguing, even in 2017 for me. And so with this, what we felt to be a paradigm shift with preschool data, we decided to have this collaboration that we entitled CPPOIT, Canadian Preschool Peanut Oral Immunotherapy. And we were the academic site, and there were 6 community offices spread out across the country. And we had 2 main aims. The clinical aim was collaborating to develop clinical preschool OIT protocols and sharing experiences. And from a research perspective, what impressed me was all of my community allergy colleagues had the same strong desire to capture data at each site to see if the clinical trial outcomes, so that Vickery study had 37 subjects, could be replicated in the real world with a much larger sample size, and so aiming for creation of a registry. And to this day, my community allergy colleagues have been really led by a passion, and they have not received any compensation for participating in this registry, which involves work, completing worksheets, submitting data. And I really want to thank them, and I'll thank them again later for that collaboration. So that was the spark, 2017. Then in the next 3 years, we had the sort of early phase of our preschool OIT experience, 2017 to 2020, where at BC Children's Hospital, we were doing all the build-up visits in person with us as the allergists. And the pilot was really to confirm safety of peanut, OIT, and other allergens in preschoolers. But very quickly we realized it was unsustainable because Kirsten has seen our clinic. It's not that big. There's 5 examining rooms. So there was lack of physical space for all of the OIT patients. There was a lack of clerical staff, a lack of clinical nursing staff, because the staff were designed for the regular clinic and not for this massive load of OIT patients. And so it was unsustainable, and we didn't really have a solution to that. We would meet with the hospital administrators, ask for more funding, of course not available. And my talk this afternoon will talk about limited resources. And then so, you know, this is the silver lining of COVID. So I talk about this a lot. When COVID hit, of course, the world was gripped with how disappointing that situation was. But the silver lining in terms of our OIT program was this transient shift to virtual allergist care for the allergy clinic, which caused a pause in the OIT. But when the in-person allergist visits resumed in the fall, and we realized that there wouldn't be the same capacity with in-person visits, but the hospital would allow us to continue virtual visits, we then decided to switch all of our OIT buildups to virtual through Zoom with research nurses. And that was made possible by the safety data that we had accumulated in that 2017 to 2020 period, together with the Vickery study and other data. So basically then we have a mix of where we have in-person visits with the allergists and clinical staff for assessments, skin prick testing, oral food challenges. This is our space showing how small it is. And then the virtual had no limit to space because you can have as many virtual rooms as you want. And so we had the research nurses doing orientations with OIT families, doing the OIT build-up visits on Zoom, and OIT maintenance visits. And again, we felt comfortable doing that because of the safety data we had in preschoolers. Together with that, it was a pivotal year, 2020, with COVID and the virtual and everything. Then, as co-lead, we published the CSACI, so the first ever Canadian oral immunotherapy guidelines, which essentially, in a nutshell, permitted use of OIT outside of research, that big, endless debate question. And so that was the main aim, and it was a systematic review. It was a very long document. The other main thing is, to this day, Canada has not had Palforzia, no FDA Health Canada licensed OIT prescription product. And so it's very important to us as Canadian allergists writing these guidelines to describe that there is no evidence that pharmaceutical products offered any additional benefit over grocery store-based food products for OIT. Now, 2020 was also an important year, so a lot of things happened that year, because at the end of 2019, I was in Houston at the college meeting, and Ed Kim had released data for his long-term peanut sublingual immunotherapy trial, where it was really for slightly older children, so school-age children, median age of 6.5. And as we expected, there was no anaphylaxis in this long-term 3 to 5 year study. But what was really nice to see was the efficacy was higher than many in our specialty imagined. So going from a baseline threshold of 85 milligram peanut protein to roughly 86% after 3 to 5 years, increasing to 750 milligram peanut protein, and even a third increasing to 5,000 milligram peanut protein. So it really was something I wasn't personally expecting. Prior to this, I was skeptical about sublingual immunotherapy. But with that publication, there was another quote-unquote paradigm shift for our program, where I decided to, again, implement this. So go right to KT and start our program for older children and adolescents, so 6 to 17, where we would use SLIT as the initial treatment step, because all the literature, the PACE systematic review, all of the literature was saying basically that OIT was too dangerous for school-age, adolescent, adult patients. Too many reactions, too many anaphylactic reactions. And so starting with SLIT seemed to be so much safer and would really address all these concerns that so many of our colleagues had about safety of OIT in older children. Over time, that's evolved into a hybrid option where we do an initial phase of SLIT followed by OIT. And I want to add that for older children, why did we have to choose this route in our program? It's because in Canada, largely speaking, especially at our site, there's very poor access clinically to biologics, omalizumab, dupilumab, for food allergy treatment. The other thing in this interval of 2020 to 2023 was crystallization of our KT for what to do with infant OIT. So these are children less than 12 months, and we published that safety outcomes were even better in infants than non-infant preschoolers, and that allowed us to make a direct linkage between failed primary prevention. Primary prevention has also been a big passion of mine in terms of KT, but directly link that with infant OIT. I'm going to elaborate on that concept more. And so, you know, you recognize that you're getting older when your patient looks like this, bigger than me. This is only a 16-year-old actually, but I show this just to illustrate our older child program. He successfully flipped from 2 years of SLIT in 2021 to just last month flipping to peanut OIT with a low-dose threshold challenge of 300 milligram protein, despite his specific IgE to peanut still being over 100 kilunits per liter. So the family was ecstatic, he was ecstatic. They were living with so much food allergy anxiety prior to that. In terms of the infants, so you know, our data has really changed the way we triage infants. Canada is a land of waiting lists, and so our allergy clinic has a rough waiting list of almost 2 years, with a further wait of 1 year for OIT after that. So a total wait for OIT 3 years for most patients. But because of the infant data and the linkage with failed primary prevention, we've decided to triage infants to be seen in our allergy clinic within 2 to 3 months of receipt of referral, and then ideally start them on OIT 1 or 2 months after they've been assessed. And so their total wait for OIT shrinks to 3 to 5 months. We're starting to have some difficulties with that because of how many infants are getting referred, and that's the subject of another talk. But yeah, it's really something that I feel most strongly about, that infant age group. Here is a case vignette, for example, how quickly things can happen ideally. So infant having a significant reaction at 7 months, having their first virtual visit with me at 8 months, being instructed to introduce tree nuts, non-choking, between 8 months, and the skin prick test at 9 months, skin prick test 10 by 8 millimeters at 9 months, and start peanut OIT in the next couple months after that. Now, how do we build research into this clinical program? So it's a bit convoluted. I'll get into how that evolved this afternoon more, but basically we're the only hospital-based academic site amongst the collaboration, and our registry basically has amassed about 1,600 patients since our first year of 2017, and we right now have about 1,200 OIT patients and 400 SLIT patients. The research program has a research manager, Dr. Leanne Solar, who we saw in the picture earlier, research nurses, a research dietitian, program secretary, and of course trainees. And I'm just going to show key publications from our research program. Our first real-world safety analysis of preschool peanut OIT we published in 2019, showing almost no severe reactions. We really wanted to describe reactions in terms of grades of severity because I had this personal bias against the words anaphylaxis and epinephrine because they're so subjective. But yeah, this really was very reassuring for us. Then we followed that up a couple of years later with our real-world effectiveness analysis of preschool peanut OIT, showing basically that 80% were able to achieve desensitization, described as 4,000 milligram peanut protein oral food challenge, tolerating that, and then 80% were able to tolerate at least, ingest at least 1,000, 98% were able to ingest at least 1,000 milligram peanut protein. That infant OIT paper that I was describing, we had compared infants with non-infant preschoolers, and the outcomes were similar, but basically the safety was even better in the infants. And so in the infant group, there was a statistically significant difference in grade 2+ reactions, both at baseline and during the build-up phase, and there were no severe reactions, no grade 3 or 4 reactions in the infants, and the effectiveness was the same. And so it really allowed us to make a case for prompt salvage infant peanut OIT following failed primary prevention, as we described in this perspectives paper here. We've done cost-effective analyses showing that preschool peanut OIT is more cost-effective than avoidance in the real-world setting. We have now gone on to publish safety data from preschool tree nut OIT, showing very similar impressive safety. We have just had a paper accepted in JACI Global for real-world safety and effectiveness of sesame OIT in preschoolers, showing similar outcomes. We are also, there was some data yesterday in the poster session about food allergy anxiety, and our group is also very interested in this topic. We developed a standardized tool called IMPACT for measuring parent food allergy associated anxiety. And we've just published some scoring guidelines for that tool for minimal, moderate, and severe food allergy associated anxiety in parents. We have just submitted for publication safety data for SLIT in our older patients, and we really wanted to focus on moderate severe phenotype and multiple food allergy, showing very good safety as we had expected. No grade 4 reactions and hardly any grade 3 reactions. And this sort of shows how we are going to follow these patients through their journey. It's been my aim to again, flip them to OIT with a low-dose food challenge after a couple years of SLIT. And that's the effectiveness first outcome that we've just submitted for publication as well, to basically bypass OIT buildup. So to summarize the program as it currently stands, the BC Children's Hospital FAITT program, we have the in-person, the combo virtual in-person new assessments, skin prick testing, specific IgE, and baseline food challenges when indicated. Then the patients go into the FAIT program where they get the build-up and maintenance visits virtually with the research nurses, either infant OIT, preschool OIT, or older child SLIT. And then they come back to the allergy clinic for in-person visits with their exit OFCs to confirm desensitization, and for the older children to do the low-dose OFCs to flip from SLIT to OIT, and eventually we'll be doing the exit OFCs after OIT as well. And so just to conclude, firstly, the debate, in my opinion, about whether OIT should be offered outside of research may never end. It still continues, and patients desire options other than avoidance. Both clinical trial and real-world safety data provide enough data for OIT to be at least offered as a treatment option. And given limited resources, preschool OIT appears to be the lowest hanging fruit for initiating real-world implementation, and what we in our program initially focused on. And even within that group, if, for example, you have very few resources, perhaps you could even just do infant OIT. So our work on real-world practical implementation of food immunotherapy is constantly evolving, and that's going to be the subject of my lecture at 4:50 this afternoon, the practicalities of implementing a real-world preschool OIT program. And with that, I'd like to acknowledge our whole FAIT team in Vancouver, as well as the national CPP OIT team and various international collaborators. So thank you very much for your attention. Thank you.
Thank you very much, Edmund, for a wonderful talk. And just a reminder to everybody, please put questions in the app and there will be a Q&A session at the end of this. So it's my absolute pleasure now to introduce Associate Professor Elizabeth